My topic is haploidentical transplant. The question is, will every patient finally have a donor? I have no conflict of interest. Actually, my interest in haploidentical transplant, which by definition is a mismatch, started or was my interest became more urgent when we actually saw a young patient who was 31, male, and some of you remember this patient. He developed insidious abdominal swelling. Then he went to see a doctor, and a liver biopsy was positive for hepatosplenic gamma delta lymphoma. And he was also strongly PET positive. What you see on this ultrasound picture here, a very large spleen, 21 centimeters in length times 7 centimeters. That's a pretty big spleen, plus the liver biopsy is positive. So indeed he had hepatosplenic gamma delta lymphoma. How you treat gamma delta hepatosplenic lymphoma? The patient, it's a T-cell lymphoma. The patient got chemotherapy, actually did not respond well, so he got salvage regimen ICE, which is an abbreviation of ephosphomide carboplatin etoposide. Since this didn't improve much the situation, he got DHAP, which is another salvage regimen. And then a bone marrow biopsy was done, which showed persistent disease. So the gamma delta hepatosplenic lymphoma had spread to the bone marrow. This picture was given to me by Dr. Cordelingam. It shows CD3 positive blastoid cells infiltrating the bone marrow. What can be done in this situation? The patient was young, didn't have any significant comorbidities. He was evaluated for transplant, got a second opinion in Tulsa, Oklahoma, and then was seen in a transplant center in Chicago. They recommended that he got 2 cycles of EPOC, which is another regimen which is used for T-cell lymphomas. He got alemtuzumab and cladribine, which are both a monoclonal antibody, and cladribine is an immunosuppressive chemotherapy. And then he got a haploidentical stem cell transplant from his brother. Despite a major ABO mismatch, the patient engrafted. And surprisingly enough, he stayed up there for a couple of months. He came to see us in clinic again in Shreveport. And surprisingly enough, his counts were a little bit low. He was in complete remission when the patient was seen. So the transplant had worked. He was supposed, he had, on day 100, he was thoroughly evaluated. He had some chronic graft versus host disease like plaques in the mouth, but overall he was doing well. The spleen had shrunk. He had minimal skin graft versus host disease, but then he got sick. He started coughing, he spitted some blood, and then he was urgently admitted actually in Chicago. And a few days later he was dead. Unfortunately, from pulmonary aspergillosis, which had been suspected for a while, but a bronchoscopy also was not clear in finding something. And that was a very fulminant death. So ultimately, the patient died in remission, but died from the complications of transplant. Aspergillosis is a common infection in immunosuppressed patients who had been on steroids, who had been, so unfortunately, the transplant was successful, but the patient died in what we call TRM, transplant-related mortality. How can we improve on this? What is the role of haploidentical transplant? We know it's an alternative transplant. And so short intersection, what to do about hepatosplenic gamma delta T-cell lymphoma. It's rare. It has a peak in adolescent and young adults. In 20%, it comes in the setting of chronic immune stimulation, as our patient. The patient has systemic symptoms, abdominal pain, hepatosplenomegaly. These this type of lymphoma, which is derived from T-cell gamma delta precursors, this type of lymphoma has a marked chemoresistance to the currently used regimen and overall has a dismal prognosis. So everybody would agree nothing else could have been done than evaluating for a transplant. Could have been done earlier, I don't know. But of course, it's a practical problem. Or how can we get a patient to transplant fast, especially if we don't do this type of transplant here. Review was published, and of course, the medical literature is full of positive case reports. 12 patients received an allogeneic transplant. The follow-up in this small case series actually is short. What I remember is 6 came into a somewhat longer remission. Let's go back for the fellows and residents. What type of hematopoietic transplants are available? This may show up in your board exam. Autologous transplant, which we commonly do here on 6th floor, is you take the patient's own cells. Allogeneic cells is somebody else's cells. Ideally, number one, it has to be a match. And the usual match is a brother or sister. However, what we have learned recently is that the matched unrelated donor from the National Marrow Donor Program is as good as the brother or sister who is a match. Among you, young people, I would encourage everybody to be a donor. It's a humanitarian decision. You do not lose anything different from a kidney donation. The stem cells theoretically are in unlimited supply for a lifetime. And so if you are a donor, most likely you will not be called any time in your life, but at least this gives the National Marrow Donor Program the possibility to search. How to become a donor? Go on the internet, be the match, and they will send you a kit to harvest your own DNA, and you mail it back, and most likely you get a letter every year that you are in the donor registry. However, 1 and 2, not everybody finds a donor. We have alternative transplants. There is cord blood and there is haploidentical, which our patient got. Anybody, a sibling, parent, child can be a match. By definition, a haploidentical transplant, may sit somewhere, there's enough chairs in front, Dr. Azari. By definition, it's a mismatch. How can this be done? Let's go back one more. Where do we harvest? Usually in these modern ages, it's mobilized peripheral blood stem cells. However, the true source of stem cells is in the bone marrow. That may come back. And also we can get stem cells from umbilical cord. The umbilical cord generally has a high quality of stem cells, but the amount of stem cells is less than in a full adult person. What are the indications for transplant? Here you see an official slide from the Center for International Bone Marrow Transplant Research. It shows both the autologous and the allogeneic transplants in 2011. Currently, I think we are around 8,000 or 9,000 allogeneic transplants per year. The indication for allogeneic transplant is the gold standard indication is AML, chronic myelogenous leukemia, which was a gold standard 10 years ago, 15 years ago, before TKIs became available, has pretty much gone away. These are patients who do not respond to tyrosine kinase inhibitors. Otherwise, acute lymphoblastic leukemia, non-Hodgkin lymphoma like our patient, chronic lymphocytic leukemia, which may also become less myelodysplastic syndrome, not characterized myeloproliferative diseases. So we have allogeneic transplant around 8,000 per year. For comparison, in the United States, per year, about 2,300 patients get a heart transplant. Much more frequently is a kidney transplant. 27,000 kidneys are transplanted every year. How does this change over time? In the years of the pioneers, around in the 1980s, this was infrequent. Now, you see related donors and unrelated donors. That is the full typing of the HLA system has made this possible. Now, in 2013, actually the unrelated matched transplants are more frequent than the family. Family is getting smaller. So and here is a slide which was much discussed at the transplant meeting in San Diego recently. Not every ethnicity has a good match in the National Marrow Donor Program. You see white European have matches in excess of 70% right now. However, Chinese, Filipino, Korean, Japanese, Native Caribbean, African Americans, Hawaiian, all have lower rates. The chances are less in non-Caucasian, non-white European. How can we change this? Look into alternative transplants. Encourage minorities to become donors. That's a safe way of changing this. So there is a need for alternative donors. Worldwide, there are large differences in transplants. Here you have a slide from the European group EBMT. In 1998, the colors were light. So Germany, as a comparison, was between 100 and 150 per 10 million inhabitants. In 2013, it increased to, I think, 400 something. Interestingly, there are countries which have a high frequency of transplant. What you see here is historically there is France, Italy, Spain, less Portugal, the Scandinavian countries, Norway, then a little bit less than Sweden and Finland. It depends on the economic development of a country setting up transplant programs. Interestingly, Israel has a high frequency of transplants because the Israeli physicians were interested in developing transplant programs. And actually some of the HAPLO was developed in Israel, the basic science into this. So overall, transplant has increased, but there is a large variation. In the United States, a slide was shown briefly at the transplant meeting. We are probably around 300 transplants per year. However, there are wide differences in country, and the slide which was shown in the meeting actually put Texas and Louisiana together. Since we don't have a transplant program here, allogeneic transplant program right now in Shreveport, I would assume that the high frequency in Houston correlates with the low frequency in Shreveport. And anyhow, what we see, what is the reason, and Dr. Glass had the wise foresight of training Dr. Mills and Dr. Burton in the allogeneic transplant. And so we had a transplant program established here, but it could not be continued, I guess, because of personnel and financing issues. Still, we have an issue, and my personal opinion on this, any high-level academic center should have an allogeneic transplant program, and there hopefully will be interest in the future re-establishing this. It's not just a physician who has to come here, it's an infrastructure of people working with the stem cells, of organizing this, actually paying for the stem cell transplant. And I had a discussion with Louisiana Medicaid. If a treatment is not available in Louisiana, they would be willing to pay for treatment out of state, so that in certain cases that could be used, this statement. But I was going to talk based on the patient initially. I was going to talk about the worldwide development of HAPLO. And I have a friend or colleague in Italy who gave me some data. In Italy, the frequency actually increased significantly from 151 to 415 per year. I asked the Center for International Bone Marrow Transplant Research to send me the data for the US. There is an increase from 238 to 400. Obviously, the United States are bigger than Italy. However, the data collection may be incomplete. So there is, everybody talks about it, and the people may not have had the time to submit the forms for documenting. And by law, we are supposed to submit all. Autologous is voluntary, but by law, allogeneic data have to be submitted to the database. It does not say exactly when these data have to be submitted. History of HAPLO. Early attempts were not successful at long term. To go back in the history of allogeneic transplant, Donald Thomas first showed that the safe infusion of marrow into humans can be done. Originally, the identical twin was the poster child of allogeneic transplant. The allogeneic twin engrafts fast, and especially in severe aplastic anemia, corrects the abnormality. What people in 1957 didn't know, or in the 1960s and 70s also didn't know, is that you need a little bit of HLA difference to have a successful long-term outcome in leukemia. The mysterious but well-established graft versus leukemia effect, which correlates with graft versus host disease. So anyhow, there were recipients from radiation accidents in Paris. Georges Maté performed the actual transplant from somebody else, which were not very successful because the people were not HLA typed. But Jean Dosset, who later got the Nobel Prize in 1980, described the human HLA antigens based on serologic tests. Today, everything is molecular. And then first, actually, pretty much same time as Donald Thomas, Maté did the first successful complete engraftment, and a patient survived over a year. And they also described acute and chronic graft versus host disease. Chronic graft versus host disease can be debilitating. People can die from it, but it's still associated with cure of leukemia. The data on haploidentical transplant were published in 1997. To make a long story short, it was a high-risk transplant. 2,055 patients of allogeneic BMTs were analyzed. In old years, it were only bone marrow transplant. And if you have a match in early leukemia from a sibling, you have 21% transplant-related mortality, dying from the complication of transplant, not from the leukemia. However, if you do a mismatch, in these early years, the mortality was more than 50%. So something which you really don't want to recommend. Here are the slides. What you see in early leukemia, the people after 5 years most likely are cured in early leukemia if you are HLA identical. However, this is leukemia-free survival. However, in early leukemia, if you have 1 antigen, 2 antigen, 4 antigen, 5 antigen mismatch, the survival chance is pretty low, but not zero. In intermediate leukemia, which means second remission of AML or CML in chronic phase, which we no longer do, the results are intermediate, but still the mismatch is on the low side of the curve. In advanced leukemia, third remission, refractory, multiply relapsed, the prognosis is universally poor. However, the survival is still not zero. So anyhow, there is room for improvement. What are the problems with haplo? By definition, a haploidentical transplant is a mismatch. So you have 5 out of 10 or 4 out of 8 antigens which are not matched. You can, first of all, in the early years, the problem is rejection. The transplant due to the difference from the residual host cells is not taken. Second problem, you can get a fulminant graft versus host disease like 2 weeks after the transplant, which can never be controlled by steroids. And then, of course, like in our patient, you still have the consequences of long-term immunosuppression. How can we overcome these problems? There are several ideas. I will, from now on, I will put this into two parts of the talk. One is T-cell depleted HAPLO, which I actually learned in Munich. T-cell deplete was not very successful. My mentor was never excited about this. So obviously, HAPLO is a mismatch. We offered it to some patients. Some people became long-term survivors, but it was not the standard of care. And then what has come by Chinese data is the unmanipulated HAPLO. The ultimate aim is tolerance. As in life, we all want to be tolerant, but also the aim is also to cure leukemia. So tolerance, yes, but not tolerance of the leukemia, tolerance of the healthy immune system, or tolerance of the recipient body by retaining the anti-leukemic effect. You have a question? No. How can we do this? A slide I borrowed from Dr. Lusnik, who worked in his career in Johns Hopkins. You can regulate energized T cells, you can eliminate removal T cells, but then we are back to the T cell depletion, which may be good for the graft versus host, but bad for the anti-leukemic effect. You can augment, you can add back after the transplant specific T cells, but you first have to grow these T cells, which is tricky in the lab. And then you can engineer. All of you probably heard about CARS. That's the prototype of engineering. And the engineering probably still needs healthy stem cells. I'm not going too much into details here. The T-cell depleted HAPLO, of course, was an early success in many years ago in children who do not have an immune system. Severe combined immunodeficiency takes stem cells easily because they cannot be rejected with a little bit of conditioning regimen. They engraft, and since they don't have an immune system, the new immune system generally takes over at not so severe price of. Then somebody in Israel developed the concept of Megadose CD34 cells that you myeloablate the patient. You deplete the T cells, and this then you give tons of stem cells, like 10 times the usual dose. This works, however, does not resolve the problem. Perugia did this, and in this context of Megadose CD34 cells and T cell depletion, the natural killer allo-reactivity can be exploited. I will show a slide about this. If there's an expert of natural killer cells among you, you probably can tell me more about this. And then, of course, you need to rebuild in the concept of T-cell depleted HAPLO, you need to rebuild the post-transplant immunity. If possible, you need to grow CMV-specific T-cell clones, you need to grow aspergillus, you need to grow an immune system targeting the common infections after allogeneic transplant. What somebody commercially has pioneered in Dallas and Houston, and actually Dr. Miller spoke about this like 2 years ago, you can transfect these T cells with suicide genes. If they get, if they take over, if they cause too much trouble, you can just switch them off. It is somewhat complicated to set this up. Another approach is to deplete of certain type of immune T cells, the alpha beta T cells, which then retains the gamma delta T cells and the NK cells. And then somebody who currently is in Regensburg developed but he trained in Stanford, developed the regular T cells. these are cells which can selectively shut down immune reactions, CD4, CD25, FoxP3. These are the Perugia data, obviously highly selected from Dr. Aversa in Perugia. What you can get under the best of circumstances, you can survive in remission 5 years in about half of the patient. You should not treat patients in relapse. So it can be done under the best of circumstances. Here is a concept of NK allo-reactivity. NK cells have their own nomenclature, and the NK cells have kill receptors, which then target the leukemia cells. If you have a kill mismatch that is inherited independently from the HLA system, then you kill the leukemia cells. If you have a match of the KIR epitopes, means the receptor on the NK cells has a match on the leukemia or any type of target cells, then the killing activity is not activated, and then nothing happens. This has been from Italy, confirmed in Poland, not confirmed in Japan. Currently, we do not type the patients for NK cells. The NK, it works only under certain protocols. They are severely immunosuppressed, so the NK cells, which grow up early after transplant, can function killing leukemia cells. So it's more for research. It's not, in my opinion, it's not for practical use. So the unmanipulated HAPLO was deemed to be impossible. However, the Chinese experience modified this. They used modified BUSAI, which stands for busulfan cyclophosphamide. All patients got severe immunosuppression after, and the mismatched patient got ATG. Sorry. Published in Blood in 2006 by Dr. Daopei Lu, conditioning, including endothymocyte globulin, followed by unmanipulated HLA mismatched HLA haploidentical blood and marrow transplantation, can achieve comparable outcomes with HLA identical sibling transplantation. Can we adopt this? Should we stop looking for sibling donors? It's controversial. People were slow in believing it. So the Chinese actually worked on this, continued treating a lot of patients. This was recently published. After a mismatch, as expected, there is more CMV antigen, which may lead to interstitial pneumonia in the mismatch compared to the match. There is more hemorrhagic cystitis. However, the survival, at least in the Chinese data, is identical, which is 50%. So, this is a leukemia-free survival and the overall survival. So leukemia-free survival is a little bit inferior to the overall survival. Actually, it took the authors a little while to get this published. The reviewers may have rejected the manuscript. The senior author presented actually this data in Grapevine, Texas at a transplant meeting 1 year ago. He was asked many questions. He could not answer all the questions. What they now have published in Cancer, which is also not the gold standard for publishing this, patients on 756 patients, 74% were standard risk, 26% were high risk. The overall survival at 3 years was 67%, and the leukemia-free survival 63%. These are exceptional data. Difficult to reproduce. The Chinese actually worked on their protocol. They actually modified the protocols, and this is the latest version of just a name you may find in the literature. They call it GIAC. GIAC stands for GCSF, intensified immunosuppression, ATG, and combination of peripheral blood and bone marrow stem cells. So we all would go back to the operating room and harvest bone marrow. In addition, that is difficult, but of course, in a country which puts the power of developing a transplant program, the Chinese no doubt have done this successfully. Can we copy this? Can we develop this here? Let's go back to the Chinese data. Who would be the best donor for a haploidentical transplant? What we see here, based on 1,210 patients, this slide just shows the incidence of acute graft versus host disease. What you see here is the better outcome, less graft versus host disease, is the donor is younger. The better outcome is a father than a mother, at least for graft versus host disease. The better outcome if the donor is male compared to female. But of course, the ultimate aim of these studies is leukemia-free survival, which is not shown in this slide. And interestingly, the NEMA mismatch is the best outcome. NEMA stands for non-inherited maternal antigens. What are NEMAs? Have you heard of NEMAs? One of the basic scientists must have studied this. NEMAs, people are in utero exposed to passenger lymphocytes which cross from the mother to the fetus, and NEMA lymphocytes, non-inherited maternal antigens, are by definition mismatched, since the child is never a full match of the parent. But the nascent immune system somehow interacts with these cells, and there may be low-grade tolerance to this. I would be careful interpreting this, but at least in the Chinese data, the NEMA mismatch has the best outcome. The Chinese, this is published in Blood and got a somewhat positive but skeptical editorial by Dr. Hans Gredinger, who developed a haploidentical transplant in Germany many years ago for children. And according to the Chinese algorithm, the most preferred is a donor as a child who is NEMA mismatched. Best second choice, younger brother, NEMA mismatched. Third choice, older sister, NEMA mismatched, or father. Last choice would be the mother. So, but we are not using the Chinese protocols. We cannot easily transfer this to our situation here. So, what came up? Some people thought about this, and Baltimore actually was one of the pioneer centers, less famous than Seattle. George Santos, who spoke in Munich actually many years ago, developed the Baltimore concept of post-transplant cyclophosphamide, which is at a pretty high dose, which makes overcome the barriers. We'll talk about this. And this is from Dr. Lusnik, who gave the education session in San Diego recently. The hypothesis is simple. After infusion of an unamended haplo mismatch graft on day 0, then of course there is some kind of immune proliferation going on. The donor lymphocytes recognize the recipient as foreign, And then there's a T cell proliferation. In the absence of tacrolimus or cyclosporin, on day 3, these proliferating T cells, which are ready to reject the cells or attack the recipient, they will be in S phase. Then, according to the Baltimore concept, patients get a pretty large dose of cyclophosphamide, 50 milligrams on day 3, 50 milligrams on day 4. Now you kill the T cells in S phase. Again, people thought that was impossible, but actually they engraft very well. So there is enough experience from, they're also using it for severe aplastic anemia without a transplant, which is probably not the standard of care. The post-transplant purging would spare T cells not undergoing active proliferation, which may include antigen-specific T cells, and hopefully some T cells exerting a graft versus leukemia effect remain. Here is the protocol, how it's done in Baltimore and in several other centers. The patient first, the recipient gets ATG on day -9, 8, 7, and then immunosuppressive treatment with fludarabine and cyclosporin is given, and the patient gets a low dose of total body irradiation, and then the donor is already mobilized. But the best source or the maximum source of stem cells is bone marrow. So we would go back to the operating room if we adopt this protocol, and then on day 3 and 4, cyclophosphamide is given after the marrow infusion, and then a somewhat conventional immunosuppression with MMF and tacrolimus or sirolimus is given. Not cyclosporin, I guess, because of toxicities. Here's a slide to explain the immunologic phenomenon a little bit more detail. I borrowed this from Dr. Lusnig. You have the recipient who interacts with the donor, and then the T cells proliferate, T cell activation and T cell proliferation. Then in the recipient, the T cells proliferate and become activated by contacting the recipient immune system or remaining immune system. The allo-reactive T cells have directly recognized foreign MHC of the haploidentical recipient. And what happens, ideally, and what probably really happens, is the allo-reactive T cells are deleted. So they are shut out. They just disappear and they die. You're probably asking, what are the data? And somebody in Italy, Dr. Andrea Bassigalupo, adopted this protocol early on. He's specializing on this. His entire hospital or entire department is working on this. And this is published by Dr. Raiola in 2013. They used somewhat younger patient, got them post-transplant cyclophosphamide plus bone marrow plus myeloablative conditioning, and the regimen included Buflu with busulfan tiotepa, Buflu, or fludarabine total body irradiation. So that's the conditioning. Somewhat younger patients, most were AML, and surprising enough or good enough, the graft failure was low. Acute graft versus host disease was on the lower side, 18%. These are all mismatched. So I think the Genova data, which is a nice city in Italy, if you should always visit, he will probably be happy to guide you for a visit. You need some special experience. So what you learn from this, actually 1.5 or almost 2 years after transplant, 68 of these patients, if transplant in CR1 and CR2, were free from disease and alive. You should not, or less likely, transplant with active disease. Dr. Raiola actually expanded this data, and now she published data last year in the Biology of Blood and Marrow Transplantation patient data on 459 consecutive patients. That's really a good series of patients transplanted between 2006 and July 2012. So it's a mix of all patients. 69% got myeloablated, still more in the younger population. What are the, sorry. And here she compared actually all patients in the hospital transplanted in this time period with the HAPLO. Again, acute graft versus host disease based on the Genova protocol. HAPLO actually is low, 14%, which is definitely better than mismatched unrelated. It's better than siblings. It's better than matched unrelated. It's better than cord blood. Again, these are selected patients. Not everybody may reproduce this. It depends on experience. It depends on protocols. Chronic graft versus host disease, which is often a clinical problem. Somebody just died from the complication of chronic graft versus host disease in our unit. It's still on the lower side with 15%. And follow-up now is 100 days. Here it's 3 years. Somewhat short, but at least it's feasible, at least in Italy, in Dr. Bazzigalubo's unit. What's the ultimate outcome? Here we have 3 years follow-up. Here we have more than 3 years of follow-up. Transplant-related mortality on the lower side, HAPLO 18%. Survival actually pretty good, at least not worse than the other types of transplant, 52%. What you see here, short follow-up. We want the cure of leukemia in our endeavors here. But it's feasible. Open questions. Where should we go? Perugia, Peking, Baltimore. What is the optimal dose and timing of post-transplant cyclophosphamide, bone marrow or peripheral blood? Who is the optimal donor? Unfortunately, I cannot answer these questions. These protocols have to be developed. What are the advantages and disadvantages of alternative donors? As we discussed, there is the unrelated match donor from the National Marrow Donor Program. First of all, you have to write a check to get the matched donor, and full service with HLA typing, provision of bone marrow or stem cells, shipping of stem cells, doing all the correspondence easily runs around $50,000. Plus the time in the unit, which is also a cost for the insurance. Taken together, different ethnicities, 50% will find a donor. There's always a time delay. We discussed this morning how to organize this. The fastest way of doing this would be a couple of weeks. And since we don't do it here, since we have to get the patient on insurance, it has to be approved, it may be a couple of months. Umbilical cord, you take it from the freezer, but it's 95% available, but it's also not cheap. One unit is 20,000 plus. If you do a double cord, it's 40,000 plus. It's low graft versus host disease. However, problem is a low cell number, and which means frequent infections in the first 3 to 6 months. A theoretical concern, no donor lymphocytes. And then you have the haploidentical. Haploidentical is cheap. Usually you don't charge family members. You just come and they volunteer the donation and being tested. 95% of the population has a mother or brother or sister or child. You may exploit the natural killer cells. It's not well defined. The Chinese have not studied natural killer cells. I didn't ask Dr. Lusnik if he has any data on the recovery or the activity of natural killer cells. However, you may increase the death from complications of transplant. It's what I would get from this. It's a project in development. Dr. Claudio Brunstein came up with the idea, since we don't know what is best, why don't we compare from Minneapolis cord blood to HAPLO? What you see here is at 1 year after transplant, the incidence of relapse and non-relapse mortality is around 20 to 30% in the cord, which actually is a double cord in Minneapolis. In his data, I think analyzing only the Minneapolis patients, the HAPLO was safe by death from graft versus host, only 7%, but their data showed 45% relapse. So that would favor the cord blood. But of course, it's tricky. You have different protocols, you have different anti-leukemic protocols before going into transplant, plus you have different ethnicities. Maybe the Chinese patients are different from the Louisiana patients, maybe they are different from the Baltimore patients. What you really want to see is the overall survival and the event-free survival. Here it's pretty much comparable in the Minneapolis data with the HAPLO, maybe a little bit better in overall survival. And plus, the trend now has been to the Center for Transplant Research has initiated a study which is not recruiting well, kind of randomizing people into going cord versus HAPLO, because the people now suddenly are convinced that HAPLO is the way to go. So that is the recruitment for the comparative study is slowing down to zero because everybody now wants to do HAPLO. Special situations. Children, older patients, adults with hemoglobinopathies. Children actually is known. It's safe. The children's immune system can tolerate a mismatch, so there are enough data in the pediatric world that HAPLO is safe if done by an experienced center in pediatrics. Older patients, Dr. Lusnik actually gave me this slide. Overall, transplant age is no longer a contraindication, older than 50, older than 60, and this may also be true for HAPLO. They have some good results, even older 60 and even 70 versus 50s. Since many older patients lack a sibling, the HAPLO option is theoretically attractive. The mini HAPLO with post-transplant cyclophosphamide has toxicities and outcomes, but it may be similar to a match. Since we are dealing with a lot of patients with sickle cell disease, and it's also tricky to find donors for sickle cell disease, Johns Hopkins, I think, has screened also hundreds of patients for sickle cell and actually transplanted 14 patients. The mortality was 0%. However, 6 of 14 came back to becoming sickle cell hemoglobinopathy. 1 developed mixed chimerism, and 7 at least had a follow-up of 1 to 3 years, became fully and stably engrafted. 6 out of these 7 patients stopped immunosuppression. They were living a healthy life, no longer having pain crisis. So it can be done. It probably needs to be developed. Dr. Basigalobo wrote a chapter for a book for which I'm editor. Here is his conclusion. I have not changed a word. Haplotransplant remain an alternative donor procedure and should be regarded as such. They are full of complications, including infections, stream infections, fungal disease, viral infections, toxicity, may occur with significant experience and expose the patients to the risk of transplant-related mortality. For this reason, whatever protocol you use, T-cell depleted or unmanipulated, Beijing versus Baltimore, should be performed in a center which has experience in unrelated or cord blood, and also the HAPLO needs special experience and should follow research protocols. As you may have heard, there are new treatments on the block, which is also immune system. PD-1 has from lung cancer and breast cancer has moved into hematology. There are nivolumab and pembrolizumab on the market. I'm just telling you as an example, there is something new. The pharmaceutical industry has steered the development of these immuno-engaging antibodies into lung cancer. But what came out recently, published in the England Journal in January, is actually it works in Hodgkin's. These are patients who have Hodgkin's disease, who relapsed or were refractory. Some of them already got an autologous stem cell transplant and brentuximab. Some of them got no stem cell transplant and failed brentuximab. Some got no brentuximab. What you see here, the response in a rigorous checking based on a small number of patients is some had 100% response, some had only 20%, but most had a better than 50% response. So we may recruit the immune system even without doing an allogeneic transplant. However, this is work in progress. I'm not sure if it's ready for use in Hodgkin's, but we can look into this. And Hodgkin's is not the classical indication for allogeneic transplant, because the autologous transplant works well in most patients, and most acute by chemotherapy, so they never need a transplant. The PD-L1 and PD-L2 is the receptors, and the cells to react need to express PD-L1 and PD-L2 protein. So there are new treatments available. Somebody from Sloan Kettering actually brings more concept. And one of our former faculty members actually works on this in New York, Dr. Koshi, but this is from the competitor group. Here is the double cord transplant combined with HAPLO, which is another frontier, and the use to the HAPLO only as a bridge. After a couple of weeks, the HAPLO is rejected by the cord. It's a tricky and probably expensive protocol. They have treated now in Sloan Kettering, and Dr. Matthias is a bone marrow fellow who sent me his data. They have treated now 50 patients with high-risk hematologic malignancies. As I said before, it's a work in progress. What are my conclusions? There are many new developments. Hematology, oncology, and the stem cell transplant is an exciting field where new concepts are developed. Different from other treatments, allogeneic transplant is an option with a chance of cure. So the patient, if you knock out the malignant cells, they never come back. Comes at the price of graft versus host disease. What is known and what is sure is that in the United States and in many countries, the haploidentical transplant generated excitement. I heard somebody from India spoke. They sent people to Johns Hopkins, and they have developed in India, South India, a transplant program focusing on haploidentical transplant, and they have pretty good results at short term. We need to learn how to manage the immune consequences of haploidentical transplant. Maybe in vitro, it's a challenge for the immunologist. Maybe in vitro, we should grow next to the transplant a healthy immune system, and then if the patient has significant complications, just infuse the immune cells targeting whatever infection you have. I think it's not as easy as it may look right now. As for LSU, I would not recommend right now to start a haploidentical transplant. There are several centers in the country interested in this, including Baylor in Dallas, MD Anderson, Johns Hopkins. There are a lot of people start working on this. Time will show what are the results. I'm indebted personally to Dr. Basigalobo and to Dr. Lusnik, who gave me their data and their slides. I used expert review from Europe about which was very cautious about the value and consideration of transplant, and Dr. Shenoy, who is originally from Louisiana and now I think in St. Louis, a pediatric hematologist, also gave me some information about her indications for HAPLO. Did I answer any of your questions, or you're totally confused? It's a work in progress. Don't hesitate to ask me questions. I'll be happy to bring you in touch with people who work on this.